Good morning. I'm also happy that I got the same, more or less, talk last year, although still I had to go through it. I couldn't remember much. So anyhow, aortic endograft infection, it's a real life-threatening complication, or we thought so up to now, of endovascular aortic repair. The data are all over the place, but the incidence is 0.2 to 8. It might be higher now with all the grafts that we use from the aortic root all the way down to the iliacs. Mortality can be as high as 88%. Less than 50%, but close to that, are gram-positive cocci, which is the best infection that you can have. And there are two types, early versus late, and management demands a multidisciplinary approach and some good planning, and diagnosis might be challenging sometimes and delayed. No large multi-institutional studies. I'll give you the ones that I have, which is they are here. So these are all a little bit old studies if we can compare to what we have right now for endovascular procedures. The largest in US is the one by Matthew Smedz from 2004 to 2014. It was published in 2016. The most recent one, and even larger, is the one from European Society of Vascular Surgery here. It was published in 2020 and had multiple patients from multiple countries in Europe. And then there was a Vascular Specialty International article, and Dr. John Ide, I think that was already when he was in Texas, he wrote this article about how to do the neo-orthoiliac system for treatment of aortoduodenal fistula after endovascular repair. NAIS was quite common, I would say 15 years ago. When I was fellow, I finished with 3. I didn't do any after that, and became less and less common. Just quickly, I have the risk factors. These are all coming from the European paper. We have preoperative risk factors. The most important are infection in a remote or adjacent site, or some other kind of infection that it's better if we have a control study that's not emergent to figure that out and treat it before. So patients with 2 abscess or with colonic lesions or UTI, these are all have to be treated. The usual intraoperative risk factors, postoperative risk factors that they have to do mostly with growing issues and graft infection, and then all the other issues, all the other disease that you can see in a patient that like malignancy, steroids taken, malnutrition, chemotherapy, and etc. Now, going to the other side, a frequent cause of infections post-op is untreated pre-existing infection. I'm going to talk about that many times because we have to keep an eye on that, set a protocol, and try to avoid all these infections. So one of them is adjunctive procedural infections like for hypogastrics, especially when we do them in an area that doesn't have the same sterility as the OR. Obviously, reinterventions, cardiac catheterization when patient doesn't take antibiotics for a long time, especially if the stent graft is already in. Dental procedures with antibiotic coverage. So we have to make sure that these patients, especially if already the graft is in, they take antibiotics and the right type of antibiotics for a long time. And the question is graft infection more common with endografts and prosthetic grafts? We used to think that it's not, but now more and more studies, they show that it is as common, maybe more. For the diagnosis of aortic graft infection, I will stay with the MAGIC criteria from 2016. These are from the European, again, endovascular surgery group, and ours, actually. And they have to do with how we diagnose this, how we determine and we diagnose this criteria. So there are major criteria as always, like pus, open wound, fistula that you already will see it, and localized clinical infections, erythema, warmth, swelling, and etc. But there also are not so obvious findings, but findings that you can only see with radiology. And those are when there is perigraft fluid for more than 3 months, perigraft gas for more than 7 weeks, right? An increase in perigraft gas volume on serial images. I had a patient like that, the third. So if you have a patient who's like 3 years out or 2 years out and now you see air around the stent graft, that's not a good thing, even if the patient doesn't have fever. Other suspicious findings are aneurysm expansion, pseudoaneurysm formation, osteomyelitis, and discitis. They are also can be something that might suggest infection. For things like that, a good test, especially if you don't see air into the graft and etc., with a CAT scan, to do either the FDG PET-CT or radiolabel leukocyte uptake test, because that will tell you if you have this kind of infection. And these are 2 tests. One is the FDG and the other one is the white cell PET scan. Treatment, I got some protocols from 2 papers. One is from the European guideline document, and the other one is from Matthews Meds, which is from 2016. The first one, more or less, we know that it's nice to keep the protocol in our mind also, so it's easier to decide. So it's, first of all, it's just to find who's fit for surgery and who's not. And the ones that they are fit for surgery and they have no fistula, they can have inline reconstruction. The ones that have orthoenteric fistula, if it is a small orthoenteric fistula, right, not with feces and everywhere in the belly, you can still provide inline reconstruction. And now it becomes more and more the first choice compared to ligation, removal of the graft, and extra anatomic bypass. I'm not going to go through all that here. It was just for TIVAR and EVAR. Most of the TIVARs, they had surgery, actually. Again, there is the extra anatomic reconstruction. I have it here. This is more and more rare. And usually we do it if we have big time infection into the abdomen with feces and etc. The most common now procedures are to do inline reconstruction, either with femoral vein reconstruction, as you can see here in the middle. Cryo-allograft, I'm not sure we use it that often anymore, and prosthetic graft which is antibiotic shock. Dr. Wright here, he had a paper to show how you can do the neo-orthoiliac system. I only have done this one where you put 2 grafts together and you connect them, 2 veins together, and you connect them up proximally. This is one that was done by one of our partners at Sinai a few years ago. They have the steps here. If you want me, I can send you the steps, just I'm trying to go a little bit faster. When we use either allografts or any other of my multi-resistant or actually graft that it's dipped into antibiotics. These are pictures for all that. This is not a picture of a graft that we use for inline repair, but whether you do inline repair or you do an extra anatomic bypass, it's important to put stents into the uterus because sometimes, because of the inflammation in the abdomen, they are all stuck and you cannot find them, and during the dissection you might get in big trouble and cause more infection. The first picture, which is this syringe, this was early way to try to remove, if you can, the upper part of the graft that doesn't have fabric and it's just metal. I think we do that less and less right now. If it comes out easily, that's fine. We don't pull. So either you put a syringe or something here. They have some other devices. This is not my experience, Dr. Wright's experience, where they put this little whatever is that, this little ring, and they try to compress the supraciliac device. But so if they don't come out, we leave them in. We have to remove all the fabric, and if you leave it in, you have to make sure that the stamp is stable and safe. And in order to do that, sometimes you need to put bovine pads, muscle fascia flap, and etc. As I said, ureteral stents are important. Aggressive tissue debridement is also important, and control of the enteric spillage. This is a patient who had gastroenteric, actually aortoenteric fistula. There was not too much spillage, as you can see, and there was clamp. That's why there's no bleeding from the ulcer here. And someone is holding the bowel to avoid more contamination. The long-term survival after surgical repair, it's not great, but it's not horrible also. The first survival graph has all the inline repairs together without separating the different grafts, and looks like it's about 40–50% in 5 years. Here they have separated the grafts to abdominal and thoracic grafts, and it looks like the thoracic grafts, they are a little bit worse. And overall, the gram-positive infections, they do better than the gram-negative. Now, if you separate, I don't have it here, the grafts according to what material we use. Obviously, the inline grafts that were done with femoral vein or antibiotic-infused graft, they do way better than the plain prosthetic grafts. Conservative treatment seems to be also an option, and of course only this study could have been done only in Sweden, where from 2012 to 2022 they treated like that 50 grafts, 42 were endografts, 40 were men. The patients, they had not too much obvious infection, and what they did, they didn't remove the graft, they didn't do the real surgery, but they did a lot of smaller surgeries, and they kept up with the patients. So they drained the abscess, they opened the sac. Sometimes they just totally resect the sac of the aneurysm around the graft. 24 patients were able to discontinue antibiotics in 16 months, and weirdly enough, 79 were alive in 3 years. I'm going to run now. I'm just going to give you this last picture only because it looks like it took me forever. And actually, this is a patient that everyone treated at Sinai from 2007. One of the people that operated on him was Dr. Carocci also. So he's somebody with Berger's disease.
You have to plan for the future, right?
He's still alive. Berger's disease. He had deep branching by Dr. Caroccio, and then abdominal aortic stent graft. Then he had open repair of the ascending aorta. He had multiple other stent grafts between. He developed, you can see all this hair. This is like about a year old now, the hair. And he developed some small bronchial branch got infected or opened into the stent graft, into the graft. The AAA actually opened the wall. And one of my partners went in and put another graft, reline it, just to keep the patient going for a long time. And the truth is that he's still alive. I think he's at his last 2 or 3 weeks now, but he made it a year after that. So I'm going to go down, but what I want to say, prevention is the best treatment, and we have to have protocols, educate patients, and educate primary physicians and everybody else who will do some procedure on these patients, and we need to have them covered for a long, long time with antibiotics. Thank you.